motility that we're really unsure of, and many times you're left with kind of an inconclusive diagnosis. So what they tried to do here is they tried to determine biomechanical properties using the impedance component to detect luminal cross-section area, looking at geometry so they could calculate things like work and power. And they looked at 12 normal subjects in this study, and remember, this was a small study. It was a validation type study. So they used 12 normal healthy subjects, and then they found 10 patients with that EGJ outflow obstruction diagnosis. Now that's the diagnosis that vexes all of us in the esophagus. They're really a difficult patient group because they really are not one specific phenotype. They have multiple different presentations. So they did a very fancy manometry protocol where they actually had these patients ingest this saline gel ball. It's essentially, it's almost like a piece of bread with a specific conductivity in it. And they did this during a typical manometry assessment. And they used this to measure the cross-sectional area and the pressure changes. Oh, here we go. And this is what the two examples, representative examples, look like on this particular patient profile. So this is kind of a normal person with normal peristalsis. This is a patient with EGJ outflow obstruction, and you can see a little bit of this pressurization here. And really trying to figure out why these people are complaining about dysphagia when they actually have still pretty normal-looking peristalsis. And this was actually a validated protocol. They had recently published on this kind of gel bolus, this novel gel bolus, so that they can actually distinguish between these two patient groups. And lo and behold, when they actually looked at this, they did uncover these very subtle differences between normal controls and these patients who were presenting with EGJ outflow obstruction. And if you can see here, one of the facts that you see that's very clear here but may not be easy to discern from back in the audience is that the actual diameter, so when the gel bolus is filling up the esophagus, it's not distending the esophagus enough. So it's really showing you that the esophageal wall is stiff in these patients, and also the pressure changes that are required to open up that esophagus to those diameters has actually increased. So this is something called Young's modulus. It's a very simple metric, really looking at elasticity of the wall, so kind of the stiffness, and it's really looking at the stress-strain relationship. And what they did show, once again, was that the elasticity, or this Young's modulus, which is the reverse of that, the inverse of elasticity, it shows that the wall in these patients is stiffer at the LES, 4 centimeters above and 8 centimeters above. So I think this was a really nice study because it's showing us that this particular patient group actually is different than people with a normal manometry. And it probably is related to some issue of obstruction and inability to distend the lumen and also open up the esophageal gastric junction. So what can you glean from this in your clinical practice? Well, if you see a patient with a normal endoscopy, they get a manometry, and that manometry looks like it's relatively normal, this may be a group that would respond to empiric dilation. Now, empiric dilation, there's always been a debate, and there have been randomized trials to show that empiric dilation may be good, it may be bad, it may do nothing. Well, I will tell you that I believe that it actually does have value. And I think if you see these kind of patients and you do a careful start low and go slow, empiric dilation in many of these patients, they will get better because you probably are dealing with some of these very subtle issues. Long-standing GERD can stiffen the wall. If people have a subtle obstruction, their muscles can hypertrophy a little bit too and get a little bit stiffer and fibrotic. And with these empiric dilations, you can improve patients. So I think this is a very nice study looking at a physiologic component that can explain a practice that many of us use. And I still do empiric dilation quite often. Another abstract that I think really highlights one of the big things in esophagology right now is that we're tying the esophagus into a lot of different disease states, whether it's rheumatologic diseases like scleroderma or certainly pulmonary and these extraesophageal symptoms. And one of the biggest things that we've really been focusing on recently is this interaction between reflux and microaspiration and ILD, interstitial lung disease. In fact, probably one of my biggest customers at our institution right now are the lung transplant surgeons and our pulmonologists, really heavily focused on reflux, proximal reflux, and microaspiration in terms of preventing ILD. And this is a study from the group in Harvard, And really what they did was they looked at this concept that if you had absent contractility, meaning that your esophagus doesn't respond very well to stimuli and propagate. So if you had these weaknesses or absent contractility, that this would lead to worse exposure of the esophagus to reflux, ergo then the chance to microaspirate, and also dysphagia from bolus retention, once again, predisposing you to having microaspiration, which once again, anything that gets delivered to the lung repetitively will cause this type of fibrotic injury. They also speculate too, that's very interesting, that once you develop ILD, it becomes cyclical, because then you're trying to take deep breaths with this stiff wall, and then you're impeding the esophageal function because now the muscle wall can't close. So a very interesting cyclical hypothesis that they've generated here. And really what they were trying to do, they were trying to look at the correlation between some of these fancier metrics, like the response to multiple rapid swallows, which is essentially having people swallow 5 times around 2 seconds in between swallows, and then seeing how well the esophagus can augment to improve clearance. And what we found in previous studies was that the actual response to multiple rapid swallow was kind of a marker that people had some peristaltic reserve, that if they got into trouble, if they refluxed, they could actually clear it. So they were going to look at this correlation between multiple rapid swallows and pulmonary function tests. And knowing their patient population, a very large patient population, this was a cohort study. There was no randomization here. But they looked at consecutive patients with ILD who were undergoing HRM, high-resolution manometry, and impedance pH as part of their routine pre-lung transplant. And as I said, these are my biggest customers at our institution, our lung transplant service. They had some exclusion criteria, people who've had previous foregut surgery, and then people who were using acid suppression. And this is what they found, and it's not surprising, and it really shows us what we probably already conceptually thought about, was the fact that in these particular patients, yes, if you had a failure of the multiple rapid swallow, so a negative multiple rapid swallow response is in red, and blue is a positive augmentation of peristalsis with multiple rapid swallows, you can see a difference in almost all of the pulmonary function tests. So FEV1, FVC, total lung capacity, and also DLCO. So this is really an important finding because now it proves to us that there is this kind of link between how well the esophagus is working and pulmonary function tests. Now, when they looked at this and they modeled this in a multivariate regression, they still saw that this kind of held true. So once again, we do know there are a lot of other factors that could affect this in terms of BMI, smoking history, and baseline assessment of primary motor function, meaning looking at primary peristalsis, and they still showed that this particular relationship was significant. So in the end, their key clinical takeaways were that intact contractile reserve independently correlated with this, and we need to kind of consider this when we're thinking about these patients. So we're probably going to see in clinical practice a lot more consultation from our pulmonologists and our lung transplant community for these particular tests. So here's another study that I thought was pretty interesting, and all of these studies actually were chosen as oral presentations at the esophageal section at DDW, so they all have significant merit in terms of their relevance. This was a really nice study, and it goes to some of the questions that we heard this morning about opioids. So just like opioids affect constipation, the lower GI tract, there is an opioid esophagus. And what we find with opioid esophagus is that in some patients, there will be a reduction in the latency interval, meaning that the peristalsis will be faster, and there will be an impaired LES relaxation. We see this typically on manometry. There were elegant studies to show this. And in fact, if you diagnose someone with type 3 achalasia, which is a spastic motor disorder, approximately half of those people are on opioids, once again highlighting this interaction. So the group from Mayo Scottsdale decided to look at this, but look at it in the context of FLIP. Now remember, FLIP is performed while the patient is under either propofol or fentanyl and Versed. So once again, this is just looking at what their baseline opioids are in terms of outpatient oral medications and seeing what the effect may be on FLIP during an endoscopy when they're assessing their motility. So here are a couple of examples of some of the typical patterns that you may see with opioid esophagus. You can see a little bit of distal esophageal spasm. You may even see a jackhammer-like pattern, an EGJ outflow obstruction because of the impaired LES relaxation, and then, as I mentioned, type 3 achalasia. Now, these are the patterns that we talked a little bit about this morning. So the top panel here is what we would see in a normal person. These are the repetitive antegrade contractions, or as we like to call them, RACs. This is what you'll see in someone who has a normal manometry. If you see that finding, you can almost be guaranteed that they're not going to have a major motor disorder. Now, if you look at that second panel, though, you can clearly see that the esophagogastric junction is not opening here, and these contractions are actually going backwards. So you can imagine if you swallowed a bolus and the esophagus started to try to push it backwards, that would certainly be a very uncomfortable scenario and predispose you to significant regurgitation and aspiration. So once again, not an optimal response, and we do see that more often in opioid esophagus. And then, of course, that bottom panel is the classic achalasia pattern, where you see really no contractile response and the EGJ is not opening. So what they wanted to do here was they actually wanted to go back and look at all of their FLIP data retrospectively and see whether or not there was a difference between the patients who were on opioids and the patients who were not on opioids. Seems pretty simple and a very nice study to see if there's any particular effect there. And they were specifically looking at these responses, primarily the responses to the volumetric distension. So when you distend the balloon in the esophagus, how does it respond? And if you think about it, it's kind of like a stress test, because your esophagus has to think about, okay, there's something stuck here. What should I do? Well, should I push it into the stomach? That would be the best case scenario. Do I just leave it alone, which is not so great? And the worst case scenario, it pushes it backwards to try to relieve the pressure. So really, what FLIP provides is a stress test for the esophagus. And really, when they looked at this, they started to see these patterns. So if you look at the patients who were on chronic opioids, 29% of these people had these retrograde contractions, these repetitive retrograde contractions. Whereas the patients who were not on opioids, none of them had that pattern. So these are kind of a patient-controlled population. They did show a very small numerical difference in the distensibility index, meaning how wide that opened. And there really wasn't a very distinct difference in terms of opening dynamics of the esophagogastric junction. So this was more related to this presence of RRCs. However, what they did show that was statistically significant, just barely, more of a trend, was that the patients that had a normal opening tended to have lower doses of opioid when you looked at morphine equivalents over a 24-hour dose. So there's probably something there, but similar to manometry, it's not a major problem for the majority of people. So really the key take-home points that they talked about here was that you can see this effect. This doesn't just translate to manometry, it also translates to FLIP. Now, the caveat here is remember, the FLIP is actually performed with some form of opioid on board, whether it's fentanyl or under monitored anesthesia care and propofol. So this is still finding this underlying point. And I think this is very important because what we find is that not everyone who gets an opioid is going to have dysphagia. And there still has to be some factor in that person's either genetic makeup, smooth muscle biology, that is allowing that esophagus to react differently to these opioids. And we've tried actually opioid antagonists, and these have not worked. And I will tell you that when you see these people in clinical practice who have an opioid esophagus, unfortunately, most of these patients are unable to stop their opioids. But if you can get them to stop their opioids, this particular phenomenon will reverse. So in clinical practice, it would be best if you could stop the opioids and see if that would reverse things. Most of the time that doesn't happen. We know the opioid antagonists are not going to affect that, not going to change anything. So really what we're left with in terms of our treatment is to treat these patients very similarly to how we treat patients who do have esophageal motility disorders. And there are many patients who have opioid spastic esophagus who do get referred for POEM. So now we come to another study, another Southern California study. So this is looking at function testing in bariatric surgery or in patients who are getting a preoperative evaluation for bariatric surgery. So this is from the UCSD group, and this is a really important topic. The more and more, we all know that obesity is a huge epidemic, no pun intended, but there are so many people being referred for bariatric surgery. Now, one of the things as someone who loves the esophagus, and I truly do love the esophagus, is that I view bariatric surgery as the most horrible thing you can possibly do to the esophagus. So if you can imagine, the whole goal of the esophagus is to push food from your mouth into your stomach. And what does bariatric surgery do for the most part? It creates an obstruction. The esophagus does not like obstruction. And what does it do when it sees an obstruction? It tries to overcompensate, just like the heart does when you have aortic stenosis. So if the valve is closed, you start to hypertrophy. So the muscles will start to hypertrophy. And what happens when it can't push it through? Well, it's not that dumb. It starts to dilate, just like a dilated cardiomyopathy. Eventually, aortic stenosis will lead from hypertrophy to dilatation. So when it dilates like that, it loses function. And early on, when people were doing lap bands, and lap bands have fallen out of favor for most people, but there were tons of patients who were presenting to us with pseudoachalasia. What would happen is they would have an obstruction at the lower esophageal sphincter, whether it's either due to the lap band or a little bit of a migration or hernia, and eventually the esophagus would give up. So they would be presenting with aperistalsis and an obstruction at the esophagogastric junction and would literally have a pattern that would be indistinguishable from achalasia unless you knew about the lap band. So this team was very thoughtful in thinking about how can we go about this and look at the best way to work these patients up. Because maybe if we figure out if there are problems ahead of time, we can circumvent this. Maybe the people who were running into this problem and generating this pseudoachalasia pattern may be people that we could pick out beforehand. And really what they wanted to do was look at all of the tests. So look at high-resolution manometry, esophagram, reflux testing, and they were looking at this in patients who were being referred for bariatric procedures. So the study design was a retrospective study design, single center over 12 months. And really, as I mentioned, you can imagine the people had a BMI greater than 35 and they were undergoing preoperative evaluation. They all had high-resolution manometry. Now, the primary outcomes were really a comparison. And we know that there are certain things that we are very cognizant about when we're thinking about bariatric surgery. And another thing that I just want to bring up very quickly is that when you're thinking about bariatric surgery for your patients too, remember, bariatric surgery, especially gastric bypass, can be an anti-reflux procedure. So if you have a patient whose BMI is 40 or above and they have significant reflux not getting better on a PPI, and you've documented that objectively, gastric bypass can be a very effective tool for those particular patients. So once again, when you're thinking about these particular patients, esophageal function is very important in that preoperative evaluation of these bariatric patients. So a very large cohort here, over 300 individuals, 247 of these patients underwent both HRM and barium esophagram. And I would tell you, at our program, not everybody gets a preoperative evaluation, but from what I understand at UCSD, they do, and that's probably the smarter way to go. Now, when they actually looked at the results, they found a couple of things that we knew already. And some of them were that, hiatal hernia is a very difficult thing to diagnose. And in fact, if you looked at hiatal hernia on HRM and you looked at it on barium esophagram, really the sensitivity and specificity in the area and the curves here were not that great. And I'll tell you, there have been so many times where I've sent people for surgery and said that they had a small hernia, and then the surgeon comes back to me afterwards and tells me this person had a huge hernia, and we just missed it. And that's because sometimes a hernia doesn't mean how high you go, it's actually how wide you go. And a huge hiatal defect can be a very difficult problem for the surgeons. And we do a very poor job of actually understanding that before the procedure, so trying to get all of these studies to get a better assessment of that is important, especially because one of the worst complications that can occur in these patients is a herniation. So if someone has a sleeve or a gastric bypass, if they herniate part of the sleeve up into the chest or the gastric pouch up into the chest, that is a very bad problem because they will not be able to empty that pouch or that sleeve component above the diaphragm. They'll have severe reflux, severe complications, and injury. So once again, although we were hopeful, this didn't really show that barium esophagram did all that much to help us in terms of improve our ability to detect hiatal hernia. Now, when they looked at acid exposure and looked at all these other factors of could they predict this, once again, results were not that great. So you can clearly see, if you know anything about area on the curve plots, that's not good. So once again, not all that much in terms of help there. So in conclusion, what we probably should be doing with all of these patients, because we don't have very effective singular tools that can pick up everything, as I mentioned earlier this morning, we need to be a little bit more comprehensive and complementary. So getting a good history and focusing your workup to the point where you're actually figuring out what the defect may be is extremely important. So if you have someone who has mild reflux before that, assess them for hernia, do a good intraoperative assessment of their hernia and repair that hernia during the surgery, because that could wind up being a big problem afterwards. So just really briefly, I just thought this was a cool study to bring up, and I was going through this, and this was one that I wasn't going to talk about really quick, but this gets to this whole AI point. And really, this was a very nice study, once again, from the UCSD group, where they used artificial intelligence and convoluted neural networks to actually go through and predict outcome. And I'm not going to spend too much time on this. I've got about 2 minutes left. But really, I kind of want to tell you a little bit about neural networks. So artificial neural networks are the way that image detection occurs on Google. It's what I talked about this morning, where you can actually see an image and train a computer to diagnose what that image shows. And the cool thing about it is you have no idea how it works. And it doesn't even need to make sense. All that matters is that you feed that input and the computer can figure out what the output is and tell you pretty accurately. And all that requires is some good data with good labeling. And what these guys did at UCSD is they basically took impedance signals, so the yellow components here, and they just fed this into a model. And over they created, and this is a little bit about the architecture of the artificial neural network, which you need to know nothing about. But what they found was that they were able to predict with a heavy level of accuracy whether or not these patients were normal or had an EGJ outflow obstruction based purely on that simple impedance signature. So in the end, I think there was a lot of really cool information at DDW this year, a lot of excellent physiology, but I don't think we should ever forget that excellent physiology, although it seems a little boring when you're first looking at it, does in the end translate to clinically relevant information. Thank you very much.
Thank you so much, John. And now our next speaker is Dr. Eddie Sofer from the University of Southern California, and he will review DDW abstracts regarding esophageal disorders. Thank you, Eddie.
Thank you very much. Good afternoon. Thank you for inviting